I'm Vanita Noronha. I'm a professor of medical oncology at Tata Memorial Hospital in Mumbai, India. I'll be talking about our phase 3 trial in which we randomized patients with EGFR mutated non-small cell lung cancer to gefitinib versus the combination of gefitinib and pemetrexed and carboplatin chemotherapy. This was a phase 3 randomized trial. The usual standard of care in patients with EGFR mutated non-small cell lung cancer today is an oral tyrosine kinase inhibitor. And the NCCN currently lists 5 EGFR oral TKIs all with level 1 recommendations. So we have gefitinib, erlotinib, afatinib, dacomitinib, and osimertinib. And the uptake in various countries is different. And there have been multiple, so all of these agents control disease extremely well, but resistance develops. And most patients develop resistance 8 to a maximum of 12 months. And following that, we need to give them various other therapies. So in order to combat this resistance, we have tried various mechanisms, and one of these mechanisms is to combine chemotherapy with an oral TKI upfront. There have been phase 2 trials and several phase 2 randomized trials that have suggested efficacy of this combination of chemotherapy with an oral TKI. So we designed this phase 2 randomized trial. We enrolled patients who were 18 years or older, patients who had stage 3B or stage 4 disease, and patients had to be planned for palliative intent therapy, and they had to have EGFR activating mutations, so in exons 19, 21, or 18. Patients had to have adequate organ function and no evidence of interstitial lung disease. So patients had to, we could enroll patients with an ECOG performance status of 0 to 2. So patients were stratified based upon their performance status, so an ECOG 0 or 1 versus 2, and the type of their EGFR mutation. So EGFR mutation 19 versus EGFR mutation in the other exons. And then patients were randomized 1:1 to oral TKI alone, so that was gefitinib at 250 milligrams orally daily, or the combination of gefitinib and chemotherapy. Chemotherapy consisted of pemetrexed at 500 milligrams per meter squared and carboplatin at AUC of 5. Chemotherapy was delivered every 3 weeks for 4 cycles. In patients who did not have progressive disease, patients continued on maintenance pemetrexed 500 milligrams per meter squared every 3 weeks. Treatment continued until progressive disease or intolerable toxicity. In patients who were on the combination gefitinib and chemotherapy arm, clinical assessment was done every 3 weeks as a pre-chemotherapy assessment. In patients who were on the gefitinib arm, clinical assessment was done every 2 months. We did radiologic assessment between every 2 to 3 months. So between August 2016 and August 2018, we enrolled 350 patients, 174 patients on the gefitinib with chemotherapy arm and 176 patients on the gefitinib alone arm. All patients who were enrolled on each arm were included in the final analysis for the efficacy analysis, and all patients who received at least 1 dose of the study medication were included in the safety analysis. So in terms of results, the median age was 53 years. Majority of about half of the patients were male. We had a large proportion of non-smokers. 83% of our patients were never smokers, and this is something that we have reported before, but maybe a bit different from the other demographic profile in other places. We had the majority of patients had EGFR exon 19 mutation, but we did include rare EGFR mutations, including exon 18, patients who had a resistant EGFR mutation if it was coexistent with an EGFR sensitizing mutation. 21% of our patients had ECOG performance status 2, and 18% of patients had the presence of brain metastasis. In terms of efficacy, the combination of gefitinib and chemotherapy led to a marked increase in the objective response rate, which was 75% as compared to the response rate of 63% in patients who received gefitinib alone. The progression-free survival in the gefitinib arm was 8 months, and that doubled to 16 months in the patients who received the combination of gefitinib and pemetrexed. This was a statistically significant increase. The hazard ratio was 0.51 and the p-value was less than 0.001. The overall survival was also statistically improved. The median overall survival in the patients who received gefitinib alone was 17 months, and the median was not reached in the combination arm. The hazard ratio for death was 0.45 and the p-value was less than 0.001. Combining chemotherapy with gefitinib did increase the toxicity. Excluding the asymptomatic laboratory abnormalities, the electrolyte abnormalities, we considered the clinically relevant toxicities, and 51% of patients in the combination arm experienced grade 3 or higher clinically relevant toxicities, as compared to 25% of patients in the gefitinib alone arm. So to conclude, the combination of gefitinib and chemotherapy led to a significant increase in the progression-free survival, which was our primary endpoint, a significant increase in the overall survival, but also increased the clinically significant serious toxicities. I think gefitinib and chemotherapy is a good alternative and a good option for first-line therapy in EGFR mutant non-small cell lung cancers. This is one of the only regimens that has been shown to prolong overall survival. Most of the other landmark trials have not shown to prolong overall survival, as to the best of my knowledge, and I think this could be considered as one of the new standards of care in EGFR mutant non-small cell lung cancer in the first-line therapy.